Good evening, everyone. Thanks for joining me. I'm Tracy Jacobs, a registered dental hygienist, and also, too, I am a professional education manager for Philips. And Philips North America, as many of you know, is a leader in the development and delivery of dental education. With that in mind, Philips Oral Healthcare is being the course sponsor and the manufacturer of Sonicare and Zoom. These products, as well as other products, may be mentioned throughout the program, and so I will present it in a balanced and objective evidence-based presentation. So tonight we'll be discussing halitosis, and many of you have heard the coined term, but may not know that it dated back to 1921. And it's readily used with our conversations when we talk to our patients, especially in the presence of oral malodor. It's almost always chronic in nature, although it may be intermittent. But think about if you've ever been in a situation where you're treating your patients and you needed to address the stinky elephant in your treatment room. Halitosis is that stinky elephant, and according to SOARS, 50 to 80% of the adult patient population experience halitosis. Neither you nor your patients want to acknowledge it. It's often ignored, and patients want a solution. And so at the end of our time together, you will embrace some new ideas for fresh breath solutions. The long-term goal, of course, is designed to help you in addressing the elephant. So we have three topics that we will uncover today, or I should say tonight. And experience, of course, tells us that fresh breath is one of the #1 motivators for our patients. In retrospect, when we really think about it as dental professionals, it's a really good motivator to achieve good oral hygiene. So we're going to talk about how can we get to the problem or the root of the problem, the source, how do we start a courageous conversation. And at the last portion of our conversation, we're going to identify some sources or maybe some etiologies so that we can have some successful clinical outcomes. Even since the ancient times, Egyptians were interested in fresher breath. The way that they would achieve that is they would take boiled herbs and spices mixed with frankincense and myrrh and cinnamon, and they would mix it with honey, make it sweet so that it could be chewed. And so there's awareness for fresher breath. It has increased over the past years. And as dental professionals, of course, we're in a great role to be able to manage and address halitosis. Think about a time when you were offered a piece of gum or even a mint. Maybe you were sitting in a seminar and your seatmate next to you offered you it. Did you ever feel uncomfortable or self-conscious about your breath? It happens to me quite often, and of course, I often wonder, are they trying to tell me something? Well, even research talks about how bad breath can become a strain on marital relationships. And so when we talk about halitosis, we know that it is one of the most common dental concerns. It affects 50% of the adult patient population. Believe it or not, 90% of it originates in the oral cavity. Only 10% is systemic. And more than 50%, if the tongue is coated, we see that with 13% that is affected with periodontal diseases. So again, research has shown that over half of oral malodor originates from the tongue coating, and 13% results from gingivitis or periodontitis. So I want you to think about back in the day, there really was no universally accepted or standardization in terminology or classifying halitosis. Miyazaki had this model back in 1999, and it wasn't until 2010 that Tangerman et al. presented this particular model. But this really, when you think about it, it's not very standardized with these older models. And when we look at the new model in terms of how to classify or how to diagnose halitosis, there are really 5 classifications. And so this makes it more simplified than the previous models. It represents the most accurate model to understand halitosis. Types 1 through 5 present different mechanisms of odor and in any combination at any time. Type 0 is a standalone classification that represents physiologic halitosis. And so again, the newer model is going to allow for multiple diagnoses in the same patient. It reflects also 2 multifactorial contributing factors. And it represents, as I said, the most accurate model to understand halitosis. Now, let me just back up for a moment and just reiterate types 4 and 5, because really as dental professionals, we're really going to hone in on types 1 and 2, type 1 being oral, type 2 airway. But type 4 being bloodborne, that is when volatile chemicals in the systemic circulation can transfer through exhaled breathing. And with type 5, it's more subjective. It can be considered normal, but again, it's something that I'll elaborate in just a moment. When we look at the 2 physiologic and the pathologic, the relativity between physiologic and pathologic, it basically is subjected to interpersonal variation. And it may fluctuate within hours, it's multifactorial. So you can have one diagnosis at one time, but you can have a different diagnosis at another time. So think about type 1 and type 3. You can have this diagnosis with the same patient, and then have that same patient again at another time have a different diagnosis and recording. So I know that it sounds very complex and convoluted, but really, as dental professionals, I think that we should focus mostly on type 1 and type 2. And as we go through the different classifications, you know, this is really our area or our scope of practice where we can offer assistance, guidance, education, and hopefully offer some solutions for our patients for fresh breath. And I want you to think about addressing halitosis more in the positive rather than the negative, because oftentimes we get really nervous about talking about bad breath. And I think that if you address the stinky elephant in the positive and refer to it as fresh breath, it'll make you feel much more confident about addressing that and sharing that with your patients. So when, again, we look at the oral classification, type 1, focusing on the tongue is our area of expertise. And when we look at the anatomical features of the tongue, we have to record the irregularity, the deep fissures. We know as dental professionals that this is a prime area for bacterial biofilms to collect. And so it's real important for us to identify this and educate our patients to see these irregularities. Whenever the tongue is coated, we also know that there are complex biofilms, and those complex biofilms can emit odor. I'll elaborate on that in just a moment. But proper tongue coating, or I should say tongue cleaning, is really critical. And oftentimes what happens is our patients really don't focus on tongue cleaning. And we're actually lucky if we can get them to focus on brushing and flossing. And so tongue coating is going to be a major concern, or one of those areas where we talk to our patients about how to have fresher breath by eliminating, if not removing, the biofilms off the tongue. Now, what we also know with tongue coating is that if an individual presents with tongue coating, that they're 6 times more likely to present with periodontal disease. The increased amounts of leukocytes that are accumulated on the tongue are a result of that. We also know that with periodontal pockets that are greater than 4 millimeters, there is an association with halitosis. When we segue into the type 2 classification of airway, this originates from the respiratory tract. So this is really going to be focusing on rhinosinusitis, tonsillitis, pharyngitis, laryngitis, pneumonia, bronchitis. So anywhere from the nose basically to the alveoli. And so when we dive a little bit more into the type 2 classifications, we want to look at postnasal drip. We also want to identify rhinorrhea or even the tonsils. Now, I will tell you that there is limited evidence to support the relationship between postnasal drip and halitosis, even though our clinical experiences have proven that it is a concern. As we look at rhinorrhea, in other words, runny nose, it's where that mucus, of course, is going to drain on the dorsal tongue. And so your patients that may present with seasonal allergies and runny nose, they may, of course, present and complain of having bad breath. Tonsilloliths or tonsil stones are another source for emitting foul odor or bad breath or halitosis. Most patients are unaware of this. Sometimes you have to bring it to their attention. Sometimes it's challenging for you as a dental professional or a clinician to even identify them. But they are common in adults. It's rare in children and infants, but they're very common in adults. And the causes for tonsil stones are really unknown. They are semi-calcified masses of debris, and they typically embed in the tonsillar crypts. When an individual presents with tonsil stones, they're 10 times more likely to have elevated volatile sulfur compounds. And 77% experience halitosis due to these tonsil stones. Now, I will tell you that the side effects of tonsil stones can be uncomfortable. They can be unpleasant. They're not life-threatening, but they present in about 10% of the general population. And as I said, halitosis is going to be the main complaint in terms of bad breath. Sometimes an individual will complain of pain or maybe difficulty swallowing. They may present or tell you that they have a metallic taste. And sometimes they'll even describe a sensation of maybe they feel like something's stuck in the back of their throat. As we move into the third classification, which is the gastroesophageal, this is the third type. There is, believe it or not, some conflicting research and data. Now, of course, this is going to be the leakage of those odoriferous volatiles from the stomach all the way up through the esophagus to the mouth and to the nose. And it should be distinguished from volatiles in the GI tract being absorbed into the systemic circulation, especially upon exhalation. So the relationship between H. pylori and halitosis is conflicting research, as well as heartburn or GERD association. Now, some of the studies tell us that stomach cancer or even ulcerative colitis may be considered bloodborne, but again, there is some conflicting research on this particular classification. And as we segue into the fourth type, again, something that you really don't need to dive too much into as far as explaining to your patients, it is something that you can be aware of, especially if you have that patient who is constantly complaining about halitosis. And bloodborne, as I said, is going to be your fourth classification. And that basically deals with the systemic circulation, where you have the volatile chemicals in that systemic circulation where there's a transfer in the exhalation, that breath exchange. Some of the systemic diseases that are classified under bloodborne halitosis can be metabolic disorders, food, as well as medication. Now, when you look at systemic diseases, some examples could pertain to the lungs, to COPD, lung carcinoma, cystic fibrosis, as well as asthma. Interestingly, also too, sickle cell, sleep apnea, kidney diseases, liver diseases, as well as breast cancer. Metabolic diseases, we're familiar with diabetes, and typically one of the symptoms that we can identify is that fruity breath that is often with our patients with diabetes. Trimethylaminuria is something that is very, very rare. It's a metabolic disorder where the body is unable to break down trimethylene. It's a compound derived from the diet that has a very strong odor. The odor emits the smell of rotting fish. And so it typically is released in sweat, urine, breathing. So the body pretty much gives off that fishy odor. And so basically it's that your body's inability to break down trimethylamine. And as I said before, it's a very rare case, but there are some cases that are presented, but that is a bloodborne halitosis. We're familiar with food. When we're practicing or seeing our patients, some of the foods that we try to avoid because we don't ourselves want to experience halitosis with our patients are the spicy foods, as well as garlic, onions, coffee, and even alcohol can emit a foul odor. The crash diets that we're often very familiar with, oftentimes whenever we are fasting, one of the side effects, of course, is xerostomia. And xerostomia not only will be a contributing factor to caries, but also, too, it can be a contributing factor to bad breath. And think about with those fad diets, some of those fad diets where the ketones are released in the breath, that protein digestion, that also too can be a source for bad breath. Again, medications. We are seeing our patients on a consistent basis, and so we're able to identify the medications that they are taking, and we know that there are probably close to, if not more than 700 medications, prescription medications that will have that common side effect of xerostomia. And so with xerostomia, typically comes oral malodor. Now, as we segue into the type 5 classification, the 5th classification, we want to focus on subjective. And subjective halitosis really can be considered normal for even some of the mentally healthy patients, but occasionally you're going to have some of those individuals that will complain about halitosis. And it can also be categorized under psychologic, which obsessive compulsive disorders, your patients who present with OCD, it can be categorized under psychologic, neurologic defects, caused by side effects through medication, hyposalivation, nutrient deficiencies, trauma, tumors, all of these side effects of all these conditions, subjective halitosis can be classified with under neurologic. Halitosis and mouth breathing in children. This is an interesting study. This is a Brazilian study that was published in 2011, and basically there were 2 groups that were identified under nose breathers and mouth breathers, and the results showed that there was an association found between halitosis and those mouth breathers. So you may have a parent who presents to you or maybe states to you that their children are their children constantly have bad breath. Well, we have some studies to identify that, if they are nose breathers or mouth breathers, that could be one of the sources as to why they are exhibiting that bad breath. Now, I'd like to activate a poll here. And so if you could tell me, true or false, 90% of halitosis originates in the oral cavity. I'll just give you about 10 more seconds to finish the poll. All right. So the answer is actually true. 90% of halitosis does originate in the oral cavity. So again, dental healthcare providers are in a key position to be able to address the stinky elephant in the room. And when you're talking to your patients about this common dental concern, speak with it in confidence and talk about it in the positive, because you know, you can offer some wonderful solutions. Now, I feel that after any continuing education, there should be a call to action. And so think about your health questionnaires when you go back into your practices and you're, you know, updating health histories with your patients. If you don't have that question about, would you like fresher breath, you might want to verbally ask them that. Or if you can modify even your digital health questionnaires. I mean, I know that many of us are using digital charts and we're able to customize our health questionnaires. You can incorporate this question. I know that when I was in full-time practice, we used to ask our patients, would you like fresher breath? We'd also ask them if they would like whiter teeth. And you know, nobody ever said no. And so when you ask that question about fresher breath, it gives you that opportunity to answer it so that you don't feel uncomfortable. You have that is your entree to be able to answer the question about one of the most common dental concerns. So as we segue into the second portion of our webinar module, we're going to talk about getting to the root of, or the source of, halitosis. And as you know, eliminating the source is the key to preventing halitosis. Volatile sulfur compounds are mainly responsible for halitosis. Volatile sulfur compounds are gases produced from gram-negative anaerobic bacteria. They lie on the surface of the tongue. These gram-negative microorganisms are foul-smelling byproducts of metabolized bacteria. They're responsible for truly 80 to 90% of oral malodor. And so these VSCs, mainly that we will identify, the primary VSCs include hydrogen sulfide, methyl mercaptan, and dimethyl sulfide. Now, I want you to know that hydrogen sulfide and methyl mercaptan, those are going to be mainly the compounds. But I'll talk a little bit about dimethyl sulfide in that they're mainly responsible for the blood-borne halitosis. And when you think about how volatile sulfur compounds smell, what do those odors emit? What does it smell like? Well, hydrogen sulfide really smells like a rotten egg, and dimethyl sulfide smells like cabbage. Methyl mercaptan, this should sound very familiar to you because it has that feces smell, and we're very familiar with this because methyl mercaptan is associated with periodontal disease. Now, how would you like to have this job? What you're seeing here is the clinician on the right is actually breathing through the nose or through the tube while the patient to the left is breathing through this tube. And so this is one way to really identify halitosis. It certainly is a subjective way. There are several methods that one can examine halitosis. I wouldn't sign up for it, but you know, you either have a subjective method or you have an objective method. The subjective method is going to be the most affordable to most dental professionals. It's very simple. can detect halitosis. Believe it or not, the human nose has wonderful senses, and it can, as I said, can be very unpleasant for the clinician. The objective method utilizes instruments as well as other types of tests, such as the salivary test. As I said about the human nose, it actually distinguishes up to 10,000 different odors. And so it basically, in using the human nose, there is a scale. It's referred to as the Rosenberg scale or an organoleptic scale. They actually call this person an organoleptic judge. And you basically put yourself, you position the nose, the clinician positions their nose about 4 inches from the source, and then it would be classified, ranked according to from 0 to 5, with 0 being no odor and 5 being extremely strong. Now, the disadvantage of this method is the reliability and the reproducibility. And you know, everyone has their own opinion about what is going to smell extremely strong and what isn't. Other subjective methods that can be utilized is the spoon test method. And so that is where the organoleptic judge will scrape the tongue, the posterior region of the tongue, and after 5 seconds, they will hold the spoon 2 inches away, and they will examine and they will classify based upon the Rosenberg scale. The floss test is another method. It's another subjective method where they'll use the string floss, unwaxed, unflavored, and they will floss inapproximately to be able to collect the biofilms. And they hold the floss sample with the biofilms about 1 inch away. And again, they will classify it according to the Rosenberg scale. You know, in my opinion, when you think about these 2 different types of test methods, the spoon test potentially reveals the odor source from the tongue, whereas the floss test could potentially reveal odor sources from the gingival sulcus. And so, although these techniques are utilized and they are a more affordable method, I feel that infection control is a huge concern, especially since you're at risk for infectious airborne agents. Now, an objective diagnosis under gas chromatography is another way to diagnose. And what's great about this is that there's no risk for exposure. There are a wide variety of gases that can be identified with this particular diagnosis tool. It's highly sensitive. It's a very large piece of equipment, so unless you're really going to focus your practice on fresh breath, you know, you'd really have to have a dedicated space. It's very expensive. I don't know very many practices that have utilized this particular piece of equipment, but you can see that it does have some advantages in order to really identify all of the different gases. Now, sulfide monitors such as the oral chroma, this is a really nice tool to consider. It detects and it differentiates all 3 volatile sulfur compounds, hydrogen sulfide, methyl mercaptan, as well as dimethyl sulfide. It is more expensive than compared to some of the other sulfide monitors. The time frame is about an 8-minute processing time, so you have to account for that in your appointment. The apparatus does need calibration. The sensors also too need to be replaced every 2 years. Another sulfide monitor that is utilized in dentistry is the halometer. Some of the advantages to this is there's not a lot of training required. However, it's not as sensitive to dimethyl sulfide. You do get faster results though. And the Breathtron is another brand sulfide monitor. Easy to use, detects all of the VSCs, And again, you do get faster results. Now, again, the sulfide monitors do have some disadvantages. Is they can cost anywhere from $2,400 to $5,000. And as I said, they do need to be calibrated regularly. And you have to replace the sensors every 2 years. An objective diagnosis using chemical sensors is the electric nose. And so, the working principle of chemical sensors is very similar to sulfide monitors, but with this, it actually, the VSCs, believe it or not, will generate chemical voltages. And so it's measured by an electronic unit, this voltage is, and so with the electronic nose, it's going to measure all of the VSCs separately. Salivary tests are becoming very widely used in clinical practice. And so this is another objective tool to diagnose halitosis. Some of the advantages is that it's inexpensive. Depending upon the test that's performed, it can identify periodontal pathogens. It can also identify karyogenic pathogens. And these are just a few of the brand names of the salivary tests that are utilized. Let's go back to our polling. And I'd like to ask the next question. And the primary volatile sulfur compounds that are responsible for halitosis include A, methyl mercaptan, dimethyl sulfide, and hydrogen peroxide, or B, methyl mercaptan, dimethyl sulfide, or hydrogen sulfide. Give you about 5 more seconds before I close the poll. So, that's right. The answer is B, methyl mercaptan, dimethyl sulfide, and hydrogen sulfide. So, as I said before, our patients are really concerned with halitosis. They're hiding behind a different kind of mask. They're hiding behind chewing gum, mints, mouthwash. And when you think about how much our patients are spending on an annual basis when it comes to fresher breath, really, they only provide short-term results. Most products are not going to be as effective, and getting to the source of the issue, of the problem, is really going to be key to having fresher breath. So as we talk about some of the solutions that are available to our patients, again, we are at a key position to be able to talk about some of the products that we can help identify the source of treating halitosis. 70% of our patients are going to chew gum. 75%, of course, are going to try to brush. And then, of course, your 49% are going to use mouthwash. When we think about the treatment needed or that protocol for recommending fresher breath or halitosis, you know, there are 5 different classifications. And so these classifications, this treatment regimen, when you think about it, we're really only going to focus on treatments 1 and 2. That is really where our scope of practice is going to allow us to make our recommendations. If we focus on anything other than that, we really need to collaborate with our medical professionals or our specialists and refer them out. And so let's talk about the different treatment solutions. And again, when the patient presents or complains about halitosis, you're gonna perform a thorough examination, and you're going to explain the source of halitosis. Obviously, you're going to instruct or provide proper oral hygiene instructions. The services that you're going to provide are going to fall under the treatment, the second treatment. That second treatment, of course, is going to be either an oral prophylaxis, professional cleaning, treatment of any periodontal diseases. That is going to be the dental treatment solution, the pathway. If the patient presents with anything beyond that, we really need to refer them out to to a physician. That intercollaboration, professional collaboration is really where you want to go. Now, some of your patients may share with you some other homeopathic alternatives. And although, again, this may provide a solution, it really is going to be a temporary solution. Some of those homeopathic solutions may include herbs. Mint is a well-renowned herb that we often find in mints and mouthwashes. Zinc as well is another homeopathic. There are some antibacterial properties that neutralize volatile sulfur compounds. Zinc does. You probably had patients talk to you about oil pulling, and oil pulling has been around for thousands of years. As you know, it involves swishing. They have to swish, solid oil in the mouth. Coconut oil, believe it or not, has lauric acid, and lauric acid has been proven to be beneficial in terms of antimicrobials. And of course, probiotics have been proven to be useful remedies for halitosis. Now, when we look at chemical solutions, we want to really identify those antibacterial properties. Chlorhexidine, as we know, is a wonderful product that we use for our patients in the presence of gingivitis. Typically, chlorhexidine, of course, is going to be prescription. And so we have to keep in mind some of those side effects and make sure that we explain to the patient some of those side effects is that it will present with stain, extrinsic stain, but also too, it can potentially alter their taste. Over-the-counter methods, when you look at recommending over-the-counter solutions, really you want to make sure that there are two important properties. Obviously an antibacterial, anything that contains cetylpyridinium chloride, essential oils, or triclosan, those are going to have those antibacterial agents that we want. But oftentimes we forget about a neutralizer. Neutralizer is what's going to neutralize the volatile sulfur compounds. And so when you look to make a recommendation for any of these mouth rinses or dentifrices, you want to make sure you have one or the other. And really you need that two-prong ingredient, making sure that you have a neutralizer and an antibacterial. Did you know that when you instruct your patients to brush their tongue, they're really only reducing 45% of the volatile sulfur compounds? And truly, the tongue cleaner is going to be the most effective way to reduce those volatile sulfur compounds. I mean, think about it. When you're brushing the tongue, it really is kind of swirling the bacterial biofilms. And your patients who present with that gag reflex, they're not going to be able to reach the posterior portion of that area. And so the tongue cleaners are going to be the most effective way to not only remove those biofilms, but also help to neutralize the volatile sulfur compound. And there are a plethora of tongue cleaners available. I typically tell my friends and my patients that, you probably want to look to some of the health food stores because you're going to find different shapes and different types with different materials. I think you should try a lot of the different varieties that are available. If you go to a trade show, you can get a lot of these as a sample so that you can experience them. You can share them with your patients to see what works best for them. But tongue cleaners have been around for centuries. Here in the States, I don't know why it is, but we consider it to now be socially acceptable. And so we here in America are finally getting to the source of it and now using tongue cleaners. But again, mechanical methods is going to be that first approach to removing the tongue, the biofilms from the tongue that harbor that bacteria. And so biofilm management is critical through tongue cleaning. This particular product is manufactured by Philips. And what's nice about the pack that you see here is that not only do you get the tongue cleaner, but there's a floss sample and there's a shade guide in there. So you can talk about two of the biggest concerns that your patients come to see you to talk about: fresher breath and whiter teeth. And this illustration truly shows the biofilms being removed off the tongue. And I like to actually show my patients how to use this. So it's really best to get from behind your patient, put that mirror in their hand, ask them to lean forward just a little bit, and you can see how you arch the tongue cleaner. And when you take it, insert it in the posterior region, show your patients how to dredge the tongue, and they'll see all of the biofilms come off. I mean, it is so compelling. I mean, I tell my patients that I think you're going to like this, that it's going to give you fresher breath longer. And you're going to want to do this every time you brush and floss your teeth. And I throw in those subliminal messages like 2 and 3 times a day. So tongue cleaners, as I said, are going to be critical in eliminating the source of the volatile sulfur compounds. The toothbrushing is really only going to stir up the biofilms. It's not going to remove them from the tongue surface. The tongue scraper is going to sweep away that tongue biofilm. And then, you know, you could recommend a chemical solution such as a mouth rinse or even a tongue spray. So Philips has a solution for breath management, and it's a 3-step system. In fact, the studies have proven it to be the most effective system for fresher breath longer. So you want to brush to eliminate the odor-causing bacteria and debris from the teeth and your gums, gingiva. You want to scrape, you want to remove the biofilm from the tongue. And then you want to sweep away any leftover bacteria by rinsing with a mouthwash that has the antibacterial as well as a neutralizer, such as zinc or even perhaps chlorine dioxide. The BreathRx mouth rinse that you see here to the left actually has zinc as its neutralizer and cetylpyridinium chloride. And so it is alcohol-free. And so it's available as in a mouthwash. It is also available in a dentifrice. And the tongue spray is really nice too, to be able to spray the tongue, scrape the tongue after you've brushed and flossed. Now, Philips did bring to market the next level of clean, and that is the Tongue Care Plus attachment. So this combines the Sonicare's 31,000 strokes along with an attachment that is very slim, and it won't trigger that gag reflex. You can see the before and after pictures and how effective the Tongue Care Plus attachment is. So this is a really nice addition for your Sonicare users to be able to use the Tongue Care Plus to get to that next level of clean. In fact, when we looked at some of the studies, it revealed that they achieved fresh breath in 60 seconds. It killed 99% of the oral malodor bacteria for that all-day fresh breath. It reduced oral malodor up to 78% better. And 96% of dental professionals surveyed said that they would recommend Tongue Care Plus along with the BreathRx tongue spray. Now we're going to go back to our third polling question. And tell me, True or false? Tongue cleaners reduce 75% of the volatile sulfur compounds. I'm going to close the poll in about 10 seconds. So the answer is true. Tongue cleaners do reduce 75% of the volatile sulfur compounds. So think about incorporating tongue cleaners into your conversations with your patients, especially when they are concerned about fresh breath. So we're coming to a close, and I just want to ask you, why is it that we're more comfortable at telling someone that they have spinach in their teeth than discussing the fact that they potentially have bad breath? Addressing halitosis can be very easy, especially when you incorporate a breath care solution. I hope our conversation provided you with some new knowledge and it empowered you to address the elephant in your treatment room. I would encourage you to incorporate a breath management system into your treatment. This will help you to address that stinky elephant in the treatment room. I want to thank you for your attention and your polling participation. If any of you are interested in the references or the resources, I'm happy to provide that to you. And at this time, I'll entertain any questions. So I want to address the question about an open bite causing malodor. Well, if the patient does present with open bite, as we know as clinicians, that xerostomia can be one of the results of open bite. And we also have learned tonight that xerostomia is a contributing factor to oral malodor. The long-term solution for halitosis truly is to constantly have those conversations with your patients. Consistent maintenance with your patients through that treatment of oral and airway. If the patient is beyond that classification of oral and airway, if it goes beyond something systemic, then you want to refer to a specialist. So I'm going to take a guess at this answer from Tyler. Does not eating cause bad breath? Say breakfast. Well, think about when we wake up in the morning. We do know that we have that morning breath. And so if you don't brush your teeth, the bad breath, the oral malodor is going to continue. If you don't eat breakfast, my professional opinion is not eating breakfast will not cause it, but if you don't brush your teeth, if you don't eliminate or remove or neutralize, then yes, it will cause bad breath. I want to address the question, what is the best way to remove tonsil stones? Manipulation. If you can get to the tonsillar crypts and you can manipulate it with a finger, with a cotton swab, with something that's blunt without having the patient gag, that would be the best way to remove tonsil stones. And I think that will probably address the treatment. There really is no treatment as the etiology for tonsil stones is unknown. A lot of tonsil stone questions. Someone asked the question about ordering samples of the Breath RX. I know that you can get samples of Breath RX through your Philips Sonicare and Zoom representative. So if you wanted to send me an email, I'm sure I can connect you with your representative. I just want to share, not a question, but an observation. An audience participant said that her son gets bad breath often. They've discovered that it originates from his sinuses, and they've used the neti pot with a saline rinse, and it does the trick. And so that again is an observation and a professional experience, or I should say a personal experience. I can tell you that my ENT, they are not advocates of the neti pot. But, you know, there you go. Another suggestion from a participant said that the ENT suggested a water pick to remove the stones. And again, if your patient or yourself, if you are experiencing tonsil stones and you can tolerate that without it triggering that gag reflex, well, there more power to you. Someone is asking the question, is BreathRx sold in stores? I believe it's available online through Amazon, and it is available through your Philips Sonicare and Zoom representative. Well, folks, I want to thank you for your time and your questions. And again, I'll leave my information up for you if you would like to have access to any of the resources.